Hello, I am Syed Razi. I'm attending thoracic surgeon at Memorial Healthcare System in South Broward, Florida. I am an SMCM and I graduated in 2006. And today I am talking about shock. So simply put, shock is defined as irregularity in blood flow that results in decreased perfusion and cellular hypoxia. Because of hypoxia, not only the cells, but the whole organ gets affected. There are four distinct classes of shock that we'll discuss in a bit. They are hypovolemic, cardiogenic, obstructive, and distributive. So the central tenet of circulation is dependent upon three important components. First and foremost is your pump, which is the heart, all pipes, which are the blood vessels, and the fluid, and that includes the blood, the interstitial fluid, as well as the intracellular fluid. So how can perfusion fail and shock happens? Three types of failure. Either your pump is failing, problems with the blood vessels, or the loss of volume. And what happens in shock? As you guys all know about the aerobic and anaerobic metabolism, during aerobic metabolism, glucose goes through the Krebs cycle and yields about 36 ATP. As opposed to anaerobic metabolism, it only yields 2 ATP and a lot of byproduct, the most important one being the lactic acid. During shock, because of the poor delivery of oxygen at the tissue level, the cells rely on anaerobic metabolism. As a result, less amount of ATP is produced for the same amount of glucose that is metabolized, and a lot of lactic acid and other acids are produced as a byproduct, resulting in severe acidosis. So how do you evaluate shock? The first and foremost is your clinical suspicion, basically how the patient looks, which we'll talk about, hemodynamic parameters, biochemical analysis, and we'll discuss each one of them in detail. And finally, adjuncts. If you have certain suspicion of various etiologies, you can use your imaging, including chest X-ray, CT scan. You can use ultrasound, echocardiogram to confirm. But again, the most important is your clinical suspicion, your history and physical examination, and so on and so forth. So clinical appearance really depends on various organ systems that are involved. And the underlying mechanism is, again, decreased perfusion. So we talk about central nervous system. Decreased perfusion to the brain leads to altered mental status, lethargy, dizziness. Circulatory system or the cardiac level, because of cardiac compensatory mechanisms, you can have tachycardia. And arrhythmias can also be induced, both atrial and ventricular. At the systemic level, you will have hypotension, decreased venous pressure. Respiratory system, the way it compensates for severe acidosis, as I just described in the previous slide. Because of severe acidosis, you have compensatory hyperventilation, resulting in tachypnea. In severe shock state, you can have cyanosis as well. Decreased renal output, oliguria, and skin examination can be cool and clammy. Hemodynamic measurements, I'm going to spend some time over here. If you suspect that somebody is in shock, you need to prove it. And you need to put that patient in a monitored setting. The first and foremost, you need a reliable blood pressure measurement, not your manual pressure cuff, because that could be misleading. So you need an invasive arterial line. And the most important metric is your mean arterial pressure, not just the systolic and diastolic. Generally, less than 65 is considered to be very low. Then cardiac output and cardiac index. These two parameters have historically been recorded via Swan-Ganz catheter. At the tip of the balloon is a temperature sensor which looks at the differential and then calculates the output, and depending upon patient's height and weight, converts them into index. However, these days, they are very reliable equipments that you can hook up to your arterial line, and they provide very reliable measurements of cardiac output index, except they are based on your arterial measurements as opposed to pulmonary artery flow that Swan-Ganz measures. So those are your important metrics that you need to be able to compute. If you have an arterial line, you can do that. Then central venous pressure and capillary wedge pressure. In order to get to central venous pressure, you need any central line. It has to be located at the cavo-atrial junction to be able to give you a reliable venous pressure. For pulmonary capillary wedge pressure, we need to float a Swan-Ganz. You guys can go over YouTube and look up a very nice illustrations of how Swan-Ganz work, but briefly put, you have to float the swan through the right ventricle into the pulmonary artery and then wedge it at one of the distal branch of the pulmonary artery. Once it's wedged, the fluid column distal to the wedged portion of the PA is in direct communication with the left atrium, and physics 101, you will be able to accurately measure the pressure in the pulmonary capillaries distal to your balloon that is wedged into the PA. And what it provides you is the pressure in the left atrium, which in a sense is your preload. However, in order to measure the pulmonary capillary wedge pressure, it requires, first and foremost, you have to have a PA catheter in place. And second, it's resource consuming because you can wedge the Swan-Ganz catheter for a brief period of time, and it has to be done by a very skilled operator because any misstep in there, balloon gets overinflated or wedged too far in, you can damage the PA, can cause catastrophic bleed. Therefore, as you can see, capillary wedge pressure is not very routinely used for patients in the ICU setting who are suspected of being in shock. In my experience, I don't recall ever using a pulmonary capillary wedge pressure outside of cardiac units. And we are able to pretty much gauge the severity and extent of shock and how it's responding to your treatments based on other metrics. Central venous pressure is a good measure, but it has its shortcomings. If you think about it, the catheter, which is in your at the cavo-atrial junction, is measuring your pressure. Any external influence can mislead or erroneously increase that pressure. For example, if the patient is on ventilator, high PEEP, high pressure support, or patient has tension pneumothorax, patient has severe pulmonary hypertension, any of these pathologies can erroneously increase your CVP and give you misleading result. So as long as you understand these shortcomings, you can still make a useful of your CVP measurements. And then your SVR, systemic vascular resistance, which is calculated either by Swan-Ganz or both your various equipments that is hooked up to the arterial line can also measure SVRs. And organ perfusion, and the best one that we have is urine output. And then lab-wise, I think the most important ones are your blood gases, both arterial and venous blood gas. Now, this is not the venous blood gas that you get from your peripheral lines. This is the venous blood gas that you get from your central axis. You want to measure these different parameters, the pH, base deficit, mixed venous oxygen, lactate, from the blood that is entering the right heart. Lactate you can also get from the arterial system, but the rest you need to get from the central line. Base deficit and lactate, as we discussed earlier, lactate is produced as a result of anaerobic metabolism, but that's not the only acid that is produced. There are other acids that is not accounted for in our routine lab analysis. So therefore, we look at the base deficit, and that's a pretty reliable measure. Normally, your base deficit should be less than 2. But if your base deficit is above 6, then that's a pretty reliable indicator that there is decreased perfusion systemically. Mixed venous oxygen is your oxygen concentration in the venous system as it has gone through the whole system. And that is dependent upon various factors. Number one, the oxygen content, which is derived from hemoglobin times 1.34 times 0.003 and partial pressure of oxygen. And then it is also dependent upon the delivery of oxygen, which is your oxygen content and your cardiac output. But most importantly, it's a reflection of how much oxygen is extracted as the blood goes through various organ systems. If you look at your arterial oxygen saturation, it's about 95 to 100% in an average adult at room air, on room air. The mixed venous oxygen or the oxygen saturation in the central vein reaching the right heart should be about 70-75%. As tissue becomes hypoxic, more and more oxygen is going to be extracted from the blood as it goes through the capillaries, which results in decreased oxygen saturation in the central veins reaching the right heart. So if your value of mixed venous oxygen is too low, and the threshold that we use typically is about 65. If your mixed venous is less than 65, that means tissues are extracting too much oxygen, and that signifies that there is a deficit in delivery. But you have to remember that shock has, there's a complex interplay of various clinical and biochemical mediators. There's no single pathognomonic test or single exam or imaging that can diagnose shock. You have to look at the whole clinical picture into context. So let's talk about types of shock. As I said, there are 4 major categories: hypovolemic shock, cardiogenic shock, obstructive, and distributive. So let's talk about them individually. If you remember these 4 categories, you will be able to place the rest of them into one of these. So you just have to remember the 4 types of shocks: hypovolemic, cardiogenic, obstructive, and distributive. Hypovolemic is easy. It's just because of loss of circulating volume. That could be hemorrhagic, that could be non-hemorrhagic. Hemorrhagic most commonly is traumatic, but there are other important causes like GI bleed, massive hemoptysis, and so on and so forth. Non-hemorrhagic could be infectious diarrhea, heat stroke, and multitude of other causes. But generally, you have to have at least like a greater than 20% volume loss that is required to produce hypovolemic shock. Normal blood volume is about 7% of ideal body weight. So, a 70 kilogram male corresponds to approximately 5 liters. Keeping that in mind, there are 4 major classes of shock. And these are some of the numbers you just have to remember. So taking that into context, a 70 kilogram male corresponds to approximately 5 liters of blood volume. Class 1 hypovolemic shock is when you lose about 15% of your total blood volume, or 750 cc. Class 2 is 15 to 30%, or 750 to 1500 cc. Class 3 is 30 to 40% blood volume loss, or 1500 to 2 liters. Or class 4 is greater than 40%. These are some of the numbers that you just have to remember. And even now, I just took my general surgery boards earlier this year, and they were still asking these questions. You just have to remember these numbers. But really, what do they mean? So let's talk about it. This may seem complex, but again, blood loss and percentage of blood volume loss, I already talked about, or that differentiates into various classes, 1, 2, 3, and 4. And then there are various parameters: pulse rate, blood pressure, pulse pressure, respiratory rate, urine output, mental status, and what's the best treatment for that. The easy way to remember is class 4 shock is when you have multi-organ dysfunction with failure of multiple organ systems. Class 1 is mostly well compensated in otherwise healthy individuals. The dangerous ones are really class 2 and class 3. Class 1 responds very well to your initial fluid replacement because the volume loss is low to begin with. And you may not even have significant derangements in your hemodynamic parameters or biochemical analysis that we discussed earlier. Class 2 is really, in my opinion, the most dangerous category. And the reason for that is we can miss it. Think about it. If you have a 30-year-old marathon runner who looks slightly dizzy after he ran a marathon, and his heart rate is 80, his blood pressure is good, and you give him some fluid in response, he will be able to compensate quite a bit because his cardiopulmonary responses are pretty appropriate, pretty adequate. So it will compensate for a significant amount of fluid loss. Similarly, in trauma, in pediatric patients, we can also see that they respond very well to initial fluid replacement in a way that it may completely mask underlying tissue hypoxia until it's very late. And that's when they often deteriorate from class 2 directly to class 4. So that's why you have to be very cognizant and very judicious that if you suspect that somebody may be going in shock, you need to very thoroughly investigate. But in terms of classification, class 2 is when you begin to see some degree of derangement in your hemodynamic parameters. So pulse pressure will go low, urine output may be borderline. Class 3 is when it's more pronounced, and class 4 is when you have full-blown shock. I think from exam perspective, what will be the highest yield is your blood loss in terms of the volume and your percentage of blood volume that is lost with each classes. So cardiogenic shock, it's a failure of the pump. Various etiologies, all of them related to the heart. The top ones are myocardial ischemia or infarction, acute coronary syndrome, arrhythmias, valvular disorders, myocarditis, endocarditis from infection, myocardial contusion from trauma, severe pulmonary hypertension. Well, it can cause right heart failure. So anytime you have patient in cardiogenic shock, there are specific protocols to treat cardiogenic shock. And I think that's probably is one category of shock where general management differs from the rest of the shock. And you have to go into individual protocols, which is clearly beyond the scope of this lecture. But I'll touch upon that later. Obstructive shock. Think about obstructive shock as obstruction of blood flow through the heart and through the cardiopulmonary system. That can happen if there is a very high intrathoracic pressure. Two common causes are tension pneumothorax and positive pressure ventilation with very high PEEP settings and pressure support setting, because both of them will reduce the venous return to the right heart. And as that happens, the right heart will output will significantly reduce. Your left heart is dependent on that, and this whole phenomena will reduce the cardiac output. Next is vascular flow obstruction that can happen from air embolism, pulmonary embolism as a result of deep venous thrombosis, cardiac tamponade, which is defined as extrinsic compression on the heart because of fluid that is present in an unyielding pericardial space. Pericardium usually holds about 20-30 cc, and you can have as little as 50 cc of blood in there following trauma or whatnot to actually cause cardiac tamponade. And then aortic dissection, any of these categories blocks the vascular flow through the cardiopulmonary system, resulting in obstructive shock. And also large mediastinal tumors with compressive effects on the airway, heart, blood vessels, resulting in shock. Some representative images. Let's look at this. So you have a patient probably complaining of shortness of breath, and then becoming maybe unresponsive, decreasing vital signs, is becoming tachycardic. Your MAP is significantly reduced. You examine him. There's no breath sound on the right. You should not have gotten this X-ray. So if you see it ever in your clinical experience, you know that you need to act immediately. And the treatment for this is chest tube. This is tension in the thorax. You can clearly see the mediastinum is shifted to the left, and the pressure is building up on the right chest, which needs to be relieved immediately. This is a cross-sectional image from a CT scan. And you can see the pulmonary artery, which is pretty opacified with contrast. This is the CT angio in the specific PE protocol. And you can see the large amount of clots in both the right and left main PA. This clot burden overwhelms the right ventricular function, which is not used to being exposed to high pressures. And now all of a sudden, if you have large clots sitting in the right and left main PA, it can cause acute core pulmonale or right heart failure. Treatment for this is if patients, even with this, again, we don't treat CT scans. So even if with this CT scan, patient is otherwise hemodynamically stable, the treatment is anticoagulation. But if the patient is having hemodynamic compromise, or going into shock, then you need to give TPA, or in most extreme instances, to go on cardiopulmonary bypass and open embolectomy, or pulmonary thrombectomy. This is the echocardiogram, TTE, transthoracic echo, where the probe is in the left, overlying the left rib cage, in the third and fourth intercostal spaces, where you can see a large amount of fluid in the pericardium. Let me see if my arrow works. So this is your chest wall, and here is all the black, which is fluid on ultrasound. So all this black represents the fluid in the pericardial space, and the heart is seemingly compressed. But what's most remarkable, this is your left ventricle, which is reasonably full. And what's most impressive is right ventricle is completely collapsed. And this happens as a result of extrinsic compression on the heart from large amount of fluid that is built up in the pericardium. This is a hallmark diastolic right ventricular collapse of pericardial tamponade. Treatment for that is you need to relieve it via pericardiocentesis and or a surgical pericardial window. And finally, distributive shock. So in distributive shock, really is the problem with the blood vessels. Either they lose their tone completely, which is the underlying pathophysiology behind SIRS-related etiologies, anaphylaxis, neurogenic shock, toxic, pharmacologic, endocrine, from adrenal insufficiency, severe thyrotoxicosis, or myxedema coma. Blood vessels losing their tone. SIRS is systemic inflammatory response syndrome, and I'll show in the next slide what are the parameters to diagnose SIRS. But there are various subcategories. Sepsis, when the SIRS is driven by an infective etiology. Trauma, anytime the body goes into severe stress, can induce this systemic inflammatory response syndrome. Trauma could be even surgical. Patients undergoing major surgery, that's a significant stress to the body, and that alone can also induce shock. So you have to keep up with all your resuscitative efforts that should correspond to the amount of trauma that is being induced to the patient. And then pancreatitis and burns, they're all SIRS related. Anaphylaxis, as you know, from either bee sting or severe allergies with massive histamine release from preformed IgE antibodies cause severe vasodilatation throughout the body. Treatment for that is anaphylaxis. Neurogenic shock, same. The vascular system loses tone because of severe spinal cord injury or traumatic brain injury, which affects the autonomic output that maintains the vascular tone. Can result in neurogenic shock. Do not confuse that with spinal shock. Spinal shock is when you have severe spinal cord injury resulting in both upper and lower motor neurons deficits. It can be accompanied by neurogenic shock, but that's a different terminology that denotes an injury to spinal cord with neuromuscular deficits. And then toxic and pharmacologic, various patients on drug overdose can also undergo into a shock state. So SIRS, what are the parameters? Number one, temperature, hypo or hyperthermia in Celsius 38, 36, heart rate more than 90 or more than 2 standard deviation in pediatric population, respiratory rate, tachypnea. Remember I told you that whenever you have acid buildup in the body, it can cause compensatory hyperventilation. So if you become tachypneic, more than 20 or more than 2 standard deviation in peds, or white count too high or too low, more than 12,000 or less than 4,000, or more than 10% bands. This is how we define systemic inflammatory response. And as we talked about, if it's secondary to infection, we call it sepsis, pneumonia or wound infections or abscesses or what have you. However, if as a result of sepsis you develop organ dysfunction or all your parameters become deranged, you call it severe sepsis. Septic shock is when you have full-blown multi-organ failure. So how do you differentiate various types of shocks based on the hemodynamic parameters? So this is the type of table that will come over and over again. So it's better to become very familiar with this. And these are all the parameters that we discussed: cardiac output, systemic vascular resistance, MAP, wedge, and CVP. And there is a bit of overlap. Different types of shocks can have similar changes in these parameters, but what's important is, and as I told you before, there is no single parameter or single lab value or single physical exam that will diagnose a particular type of shock. You have to look at the whole clinical picture into context. You have to focus on the history and physical, find the etiology, and then decide which type of shock patient is presented with. Oftentimes, there are a combination. You can have a patient with severe hypovolemia from trauma or whatnot and go into sepsis. You can have those combinations. oftentimes, after open heart surgeries, patients can go into septic shock. So they can have a component of cardiogenic and septic shock, and so on and so forth. But to look at them individually, in hypovolemic shock, your systemic vascular resistance will go very high. Cardiac output, it could be high, it could be low. Remember, cardiac output is dependent upon stroke volume and heart rate. You may be able to maintain your stroke volume, which is about 50 to 70 cc, but if your body is not receiving, if your organ systems are not receiving adequate amount of perfusion, then to make up for that, the heart rate will go up. So I'm not entirely sure if it's really correct. I should have looked it up earlier. It could be high, it could be low. But SVR definitely goes high in hypovolemic shock. Your MAP may be normal in the beginning and then goes low. Your wedge will definitely be low because, as I said, the preload on the heart goes low, and CVP would be low as well. In cardiogenic shock, cardiac output again goes low. Your vascular resistance goes high. MAP depends whether it's compensated or non-compensated. Your wedge will be very high because, remember, it's a pump failure. So your heart will be receiving adequate amount of preload. It's just is not able to process it and pump it forward. So it's a pump failure. And CVP will, as a result of the pump failure, will also go high. In case of obstructive shock, such as tension pneumothorax or tamponade, again, your cardiac output will go down. Your SVR will go high. MAP, again, if it's compensated, maybe normal, could be low. If you do a wedge at that time, your wedge will be very high because there is significant intrathoracic pressure, and your CVP will be high. In case of distributive shock, now this is where things go a little bit different. You see that the systemic vascular resistance will go low because there is vasoplegia. There is no vascular tone. So same in case of septic shock, your SVR goes low. And cardiac output in the early phase, it may actually increase as the body tries to compensate for it. And your CVP will be lower. So physiologic response, how does the body react? Two phases: a rapid response, which happens immediately, and then a more sustained response, which ensues after about 24 to 48 hours later. The rapid response is your flight and fright mechanism. All your stress hormones, epinephrine, norepinephrine, are released from the adrenals, resulting in vasoconstriction, increased myocardial contractility. This happens almost instantaneously. And then a more sustained response ensues, and the predominant mediator is decreased renal blood flow. As the hydrostatic pressure is reduced in the glomerulus and tubular system of the kidneys, there is increased renin secretion from the juxtaglomerular complex. And that activates the RAA system, which is your renin, angiotensin, and aldosterone. The renin cause angiotensin 1, which is secreted from the liver to be converted to angiotensin 2 by the lungs. And angiotensin 2 is the most potent vasoconstrictor known. Second, renin also increased secretion of aldosterone, which is important in salt and water retention on the body. Angiotensin 2 in turn also stimulates all the stress hormones, which are your epinephrine, ACTH, cortisol, glucagon, and arginine vasopressin, also known as ADH. The cumulative effect of all these neurohormonal responses is salt and water retention. Increase glycogenolysis. You are going to start consuming all your glycogen stores to produce energy. And especially if you need to be able to keep producing ATP at the cellular level, and there is not enough oxygen, the cells will rely on glucose to undergo anaerobic metabolism. So you can pretty much deplete all your glycogen stores within a matter of 24 to 48 hours once shock ensues. Lipolysis and protein catabolism, which causes negative nitrogen balance. And finally, immunoinflammatory response, which can have significant deleterious effects on various organ systems. The predominant mediators are tumor necrosis factor alpha and interleukin-1. In particular, the lung takes the biggest hit as a result of this immunoinflammatory response and cause severe ARDS in severe shock state. So phases of shock, which I already described: compensated shock, when your intrinsic regulatory mechanisms and all the neurohormonal mechanisms are able to control the initial insult and the vital organ function is maintained. This is the state. This is called compensated shock. Your patient may remain hemodynamically stable, but you may or may not have some degree of deficits on your biochemical analysis. You may still have high lactate, high base deficit, and with further treatment, you can completely reverse this process. This is the compensated shock. The uncompensated shock is when you have ongoing compromise of microvascular perfusion. This results in deterioration of organ function, and hypertension develops along with various organ dysfunction. Irreversible shock is the extreme status where the organ damages are irreversible. Complications of shock. Ischemia reperfusion injury is one of the most important ones. And I think of IRI is driven by reactive oxygen species. So as your tissue becomes hypoxic, neutrophils, macrophages, and epithelial cells, which usually have a protective role in maintaining organ homeostasis, they become primed and they become reactive. And when perfusion is restored, we often see an exaggerated injury level. And that happens because those same cells, which are primed now, will produce excess amount of these reactive oxygen species or free oxygen radicals. Some of the most damaging ones are superoxide, hydroxyline, and hydrogen peroxide. And it's not an all or none principle. It really depends upon the extent of ischemia reperfusion injury is really dependent upon the balance between the reactive oxygen species as well as the antioxidant defense mechanisms. If those defense mechanisms are overwhelmed because of the initial insult of ischemia, then ischemia reperfusion injury ensues, resulting in more dysfunction that is otherwise attributed to ischemia alone. This ischemia reperfusion injury is a predominant pathophysiologic mediator behind the development of respiratory distress syndrome. And the other complication shock that we discussed, multiple organ dysfunction. And this triad, which has a very high mortality. If you see a patient in severe coagulopathy, DIC kind of picture, hypothermic and acidosis, then that's a very critical state. And it's very difficult to reverse the process unless the source is controlled. Treatment. First and foremost, you have to recognize that the patient is in shock. Once you do that, the first thing is you have to stabilize the patient if the patient is in severe shock. And then try and recognize the type of shock, because there are specific treatments for different types. As I said, if the patient is in cardiogenic shock, then the treatment is different than the remainder of the shocks. But for hypovolemic, obstructive, and distributive shock, you can always start with volume just have 2 large bore IV lines, 16 or 14 gauge, and just infuse volume. And if you're confused, you can always just give more volume. You can never harm someone, even if the patient has tension pneumothorax. If you give more volume, you're increasing blood return to the right side of the heart. That may help, will definitely not treat the underlying condition, but it will not harm either. So if in doubt, and if you have ruled out the cardiogenic etiology, you can always load the patients with volume. And you have to address preload, afterload, and the pump function. The best way to address the preload is always volume loading. And then the questions arise: what type of fluid do you give? How much fluid do you give? What are the endpoints of resuscitation? So let's look at that. Your resuscitation fluids are 3 types, the way I think of it: crystalloids, colloids, and blood transfusion. Crystalloids, the 2 common ones that we use, normal saline and Ringer's lactate, used universally. They are almost isoosmolar, and there are some other configurations that are available in the market: osmolite, plasmolite, and so on and so forth. They are maybe more isotonic than normal saline. But having said that, these are the 2 most common ones, and patients in shock response very well to these if the inciting insult is not very extreme. Colloids, the difference between crystalloids and colloids, as you guys know, is colloids maintain oncotic pressure, and they're often derived from blood products as well as synthetic. They are able to maintain the oncotic pressure such that the amount of volume that you infuse remains within the intravascular system, as opposed to normal saline and Ringer's lactate, where 2/3 of the volume will dissipate in the interstitium. There are instances where colloids are more beneficial than crystalloids. And one particular example that I can think of off the top of my head is burns. And all the studies have actually shown that shock associated with burns responds well to various types of colloids. But having said that, I think the first line treatment for resuscitation for patient in shock is crystalloids and not necessarily colloids. But what's the ideal colloid? That's your blood. So if the patients don't respond to crystalloids after, for example, in trauma setting, we typically use a rule of 2. So the patients don't respond to 2 liters of immediate crystalloids, we start giving blood transfusion. And for blood transfusion, if you have time available, or if you have type-specific blood available, then you give the type and crossed blood, but it takes time to prepare. In case of emergent situations, for example, in trauma, we can use O-negative blood. After volume loading the patient, if they continue to show signs of derangement of your hemodynamic parameters, you can use various pressors. You need to know these pressors cold, hands down. You need to know which receptors they act upon. So I'm gonna briefly take you through. Norepinephrine, epinephrine, these are also produced by the adrenal medulla. And vasopressin, phenylephrine, and dopamine. Alpha-1 receptors, they're responsible for vasoconstriction. Beta-1, beta-2 primarily acts on the heart. Beta-1 is is primarily responsible for your inotropy. And beta-2 acts both on the heart and the vessels. And then there are dopamine and receptors and vasopressin receptors. Norepinephrine, it has both inotropic effect as well as vasoconstrictive effect. The difference between norepinephrine and epinephrine is epinephrine has more of an inotropic effect on the heart, in addition to the vasoconstrictive effect that norepinephrine has. I think outside the cardiac world, where patients undergo open heart surgeries um, and open heart surgeries with use of cardiopulmonary bypass machine, where they have significantly reduced cardiac activity postoperatively often. We use epinephrine fairly routinely, but outside the cardiac world, the use of epinephrine for treatment of shock is very, very limited. So Levophed or norepinephrine is your pressor of choice because it gives you optimum vasoconstrictive effect as well as inotropic support to the heart. Vasopressin is a very important adjunct. It acts on the vasopressin V1 receptor in the blood vessels, and it does two things. It is involved in water retention in the kidneys, it's an antidiuretic hormone, but it also potentiates the effects of catecholamines. And patients in septic shock responds very well to a combination of Levophed and vasopressin. Phenylephrine is your pure alpha agonist, has no beta activity. There are instances where phenylephrine can be very helpful, such as neurogenic shock, where the pathology is purely loss of vascular tone. But in instances such as septic shock may not be very helpful, at least to be used solely in the beginning, because severe alpha-1 activity will have cardiac depressant effect as a reflex. And then dopamine have multitude of effects depending upon the dose concentrations. At low doses, it was said to be renal protective. New data suggest it may not be as valuable as we thought it was. And then at intermediate to high dose, it can have vasoconstrictive as well as inotropic effects. And I forgot to add, but dobutamine is another purely beta-1 agonist, which doesn't have vasoconstrictive effect. That could be used in patients with cardiogenic shock. So you need to know these pressors really well. And what are the endpoints of resuscitation, the goals? There are, if you look at the literature, there are various algorithms to diagnose shock, how to manage it, how to treat them, and what should be your endpoints. I think the best approach is whichever parameters you are using to diagnose the patient and monitor the patient's progress, your endpoints of resuscitation should be normalization of those same parameters. So definitely your vital signs should return to normal. Your MAP should be above 65. If you have been using CVP and mixed venous oxygen, they should normalize. Your ideal CVP should be 8 to 10, but if the patient is on ventilator, it should be 12 to 15. Mixed venous oxygen that I described earlier is your oxygen saturation in the central veins. It should be above 65. End organ perfusion, which is your urine output, is the most reliable metric, should be at least half a cc per kg per hour. In pediatric population, because they have high concentration of free water, we use 0.5 to 1 ml per kg per hour. If you have been following cardiac index, cardiac output, they should normalize. Cardiac index at least 2.2 and above. Lactate levels and base deficits should also normalize. So in summary, the most important thing in the management of shock is prompt recognition. Every hour you delay the treatment, mortality increases. If in doubt, stabilize the patient first. Remember your fluids. If you don't know the etiology, and if you are sure that it's not from cardiogenic shock, you can always start with fluids and then work to your etiology and look for the underlying cause. Well, I hope this lecture was helpful. This educational activity was supported by Jinnah Medical University Alumni Association of North America. Again, I'm a thoracic surgeon at Memorial Healthcare System in South Broward, Florida. My email address is srazi@mhs.net. If I can be of any help, please do not hesitate to contact me. Thank you.